I'd like to start off once again by thanking Professor Jelsmuth for organizing this conference. I would like to especially acknowledge the kindness and hospitality shown to me by the entire child neurology group at the University of Pretoria, who have gone out of their way to make me feel at home, taking me out for dinner, explaining to me what a bucky is. I spent that was a little bit of a mystery, interpreting an Afrikaans menu. There were all sorts of all sorts of highlights that I will remember for a long time to come. It's also been a pleasure to meet many of you in the audience and to spend some more time in what is really quite a remarkably beautiful country, which seems to have the perfect climate in the month of March. Anyway, my job now is to talk about current strategies in the prevention and management of cerebral palsy, and I was told that the attendees wouldn't necessarily be the same from day 1 to day 2. So the first 8 to 10 slides in this presentation are the setup slides, and those of you who were here yesterday probably have seen them, if you were awake, which I hope you were, have seen them before. So we start off again with the definition of cerebral palsy. I won't belabor the point. It's a permanent disorder, movement and posture that causes activity limitation that is a result of a non-progressive pathology in the not yet mature brain. As we've heard, the motor disorders of CP are often accompanied by other things, by disturbances of sensation, perception, cognition, communication, and behavior, by epilepsy, and by secondary musculoskeletal problems, as we heard from a previous presenter earlier today. So this emphasizes the heterogeneous nature of cerebral palsy. The diagnosis is one that requires inclusion and exclusion criteria. It's a diagnosis that is uniquely clinical. It's not made on the basis of a single lab test, nor is it based on an imaging study alone. It reflects both congenital disorders that are present at birth. Indeed, some of the congenital disorders are present at the moment of conception. And it also represents a group of acquired disorders that may represent an acquired injury or disturbance or disruption in the not yet mature brain. The origins of CP can be in any of the epochs that is encountered, prenatally, perinatally, or postnatally. But the one thing that all of these children have is an objective findings on neurologic exam or a motor delay, which collectively we call a neuromotor impairment. Again, chronic disorder, there's no magic wand. We can't cure the disorder, but we certainly can make every child we encounter better in some way in order to achieve their optimal outcome. It's also a disorder that is present across the lifespan, and it's one of the neurodevelopmental disorders because it does invariably affect progression in at least one or more developmental domains. It's also never the same disorder twice. As I said yesterday, if you've seen one child with cerebral palsy, you've seen one child with cerebral palsy. And it encapsulates in a single disorder all the varied challenges encountered in the most remarkable of specialties, that of child neurology. And indeed, to know cerebral palsy is to know pediatric neurology. And indeed, I tell my residents, if there's one chapter in the definitive textbook of pediatric neurology that they should read, it's the chapter on cerebral palsy, and they say why? Because to know it is to know pediatric neurology, and I also wrote the chapter. The comorbidities are frequent, and they're often the major individual health and family burden. As we've heard, it's typically diagnosed provisionally by the age of 2, and it's confirmed by the age of 5. It's a frequent disorder. It affects in the high resource setting anywhere between 1.5 to 2.5 per 1,000 live births. It's lifelong. There are some well-recognized, identified risk factors. Keep these in mind because these are the sources of our prevention strategies. Prematurity is the big one. Maternal newborn infection, birth asphyxia, birth trauma, and newborn jaundice. The disorder has a high associated morbidity and cost. In North America, in the most recent estimate, which is now at least a decade old, it is estimated that the average child with cerebral palsy over the lifespan will have an additional cost to our education and health service system of about $1.5 million, okay? Whether that's US or Canadian dollars, that's still a heck of a lot of money. And a lot of the associated morbidity lies in the comorbidity, the epilepsy, the intellectual disability, the sensory impairment, the behavioral challenges, and the orthopedic limitations. The causal spectrum, as I highlighted, varies according to the subtype of CP and whether or not the child originally spent time in a level 3 NICU. We heard earlier today the detection of CP. You heard from a superstar, Iona Novak. It's very fortuitous you were able to connect with the video and with the phone afterwards. Technology does work occasionally. And the detection is really based on a solid knowledge of the expected motor milestones of the infant. Rolling over between 4 to 6 months, sitting unsupported when placed between 6 to 9 months, pulling to stand between 9 to 12 months, and walking independently between 12 to 18 months. There are some recognized red flags which should raise the question in the parent, or more importantly in the primary care provider, that the child may have CP, that the child who's not rolling by 6 months, not sitting by 9 months, and not walking by 18 months. Early preferential handedness before the age of 1 is another red flag. Seizures, especially if they begin focally, may also be a red flag. An admission to a neonatal intensive care unit after birth immediately imparts on the child an increased risk of later cerebral palsy and other neurodevelopmental disorders. And typically, newborns are admitted to NICU because of prematurity, presumed birth asphyxia, congenital heart disease, infectious challenges, whether it be sepsis, meningitis, or encephalitis, or hyperbilirubinemia. There are prenatal causes that are present before the mom goes into labor and before she gives birth. They are actually the major source of causes for cerebral palsy, and as I highlighted yesterday, they include cerebral malformations of any type, in utero infections, the big one being toxoplasmosis, rubella, cytomegalovirus, herpes, HIV in this nation, and syphilis. And chorioamnionitis has emerged in the last decade as a well-recognized increased risk factor for later cerebral palsy. Another common prenatal cause, and this is the misprint, is prenatal arterial ischemic strokes, as well as in utero hypoxia, occurring between 26 and 34-week gestation that may lead to later periventricular leukomalacia. And also the pattern of prolonged partial asphyxia may occur antenatally before the process of labor has begun, and that too can lead to later CP. Perinatal causes refer to ones which occur typically around the process of birth or delivery or early in the newborn course, and this includes the CNS sequelae of prematurity, including interventricular hemorrhage and periventricular leukomalacia, and I'll be going into the pathogenesis of PVL. It was a question yesterday, and I have the slides here to show you how that happens. Birth asphyxia, whether it's prolonged partial or acute near total. Birth trauma related to operative attempts to deliver the baby, whether by using a vacuum or a forceps. Neonatal meningitis, whether it be by group B strep, E. coli, or listeria, which are the big three. Neonatal encephalitis due to herpes, kernicterus. And then we also have a variety of neonatal stroke syndromes which occur around the time of delivery, which may also lead to later CP. Postnatal causes are relatively rare in high-resource settings. These are things that begin after 28 days of age, up until usually the upper limit is around 2 years of age. And in high-resource settings, these are typically CNS infections, whether they be meningitis or encephalitis, shaken baby syndrome, as well as acquired traumatic brain injury, whether accidental or non-accidental. And sometimes the baby can have a stroke after the newborn period as well. I would imagine these postnatal causes as a percentage of CP is higher in a nation like South Africa, probably because of higher CNS infection rate, and looking how people drive here, and how many individuals can be packed in a car, I assume that motor vehicle accidents and traumatic brain injury may also occur much more frequently. There seems to be an understanding that a stop sign here means you slow down, and those speed bumps, you know, Canadians come to an almost complete stop before those speed bumps. I think you guys say, oh, this is the time to have some fun at the amusement park, and let's see if I can get my passengers to bounce up and down. Which I did in a bucky, by the way. Okay. All right. On my way to a brie, right? How's that? Okay. So CP, the evaluation of CP, there is a practice parameter statement, which is the guideline. It's from 2004. The main thing on that is to do an imaging study. Every child with CP should have an imaging study, preferentially an MRI compared to a CT scan. I just put up this slide because this highlights the increasing role of genetics in our understanding of cerebral palsy. And this paper in Nature Communication a couple of years back was a big hit. I've never seen a paper of mine get more media coverage than this one, and it really showed a high frequency of microarray abnormalities in an unselected population of children with CP. Previously, such things have been shown in selected populations, but this was actually an unselected. So when you're evaluating a child medically for cerebral palsy, whether you're a child neurologist or a developmental pediatrician, you need to screen for sensory impairments of hearing and vision. Why? Because they're present and they're correctable. You need to screen for developmental delay or intellectual disability because that also imparts certain remediation efforts. You need to screen for behavioral challenges because that may also mean non-medical or medical management issues, as well as feeding difficulties. Unfortunately, many of these children may also have a coexisting seizures disorder, so if there are any paroxysmal disorders suspected, an EEG should be done. As I mentioned, neuroimaging, in particular an MRI, if available, should be the sine qua non of the medical evaluation, with a 3 Tesla scan preferable to a 1.5 Tesla scan. I have had situations where the 3 Tesla scan revealed an underlying focal abnormality to explain a child's CP, which was missed because the 1.5 Tesla scan was interpreted to all eyes as completely normal. Microarray or comparative genomic hybridization is emerging as a routine test in high-resource settings, with about a 10 to 30% yield on, depending on the sampling characteristic. Certainly it's indicated in atypical CP, which is characterized either by normal imaging, no apparent etiology of family history, or dyskinetic CP without any evidence preceding connectress or birth asphyxia. The debate now is whether microarray should be done routinely on all children with CP, even those with a clear, for example, obvious etiology. In addition, also, sometimes specific genetic testing may be indicated by what you find on imaging study. For example, if you find specific cortical malformation, you can then do genetic testing to look for the specific gene responsible. Classification of CP, I went over that yesterday. The neurologist and developmental pediatrician classify according to the neurologic subtype based on the quality of motor impairment, and if it's spastic, it's anatomic distribution. The big categories are spastic, dyskinetic, and ataxic hypotonic. Some people also add a mixed classification scheme which combines both spasticity and dyskinetic movements. Many people will just simply categorize those children as dyskinetic. Functional stratification has emerged in the last decade or two as a key way of classifying these children, and we have 3 great standardized functional classification system. I went over in detail yesterday the gross motor function classification system that looks at gross motor skills or ambulation, I also went over the Manual Ability Classification System, or MACS, which looks at bimanual dexterity and fine motor skills. And I also mentioned the Communication Function Classification System, which stratifies language and communication skills in a functional way. There's also now emerged a feeding classification system. Each of these are standardized, they're stratified in very congruent parallel fashion into levels from level 1 to level 5, from least impaired to most impaired, and they impart severity, and they also impart what rehabilitation needs are necessary. In addition to classifying the child with CP, the physician needs to ask the question, is there an underlying cause? Most important thing they probably do is make sure that that child is hooked into appropriate rehabilitation services. Typically that starts in a hospital setting, but there's no place in the world where a pediatric hospital can maintain all of these rehabilitation services, so usually there are community resources that the child is then transferred to. You need to identify comorbidities, and as was mentioned by our previous speakers, and is also highlighted in the presentation by Mr. Nelson earlier today, counseling and support of the family regarding the diagnosis is extremely important and should not be minimized, and is probably one of the most important things you do medically. In terms of classifying the CP, all the kids that I see in my clinic will have the neurologic subtype, they will have the functional classification scheme, and they will also have a list of coexisting comorbidities if present. So epidemiology also guides us in terms of what are our prevention strategies. It's the most common cause of pediatric physical disability. The frequency is inversely related to gestational age. The more premature the infant, the more likely to have later cerebral palsy, with the rate going from 82 per 1,000 births if the baby is under 28 weeks to just 1.35 per 1,000 births if above term. 45% of CP occurs in preterm birth, but preterm births probably account for maybe 10% of births in a total cohort. The frequency is also increased by low birth weight, being small for gestational age, or intrauterine growth restriction independent of prematurity. The rate of later CP is increased in the setting of maternal infection, whether it's based on clinical signs, which can also often not be present, but is also increased on pathologic signs in the placenta of maternal infection. Fetal and newborn infection also increases the rate of later CP. CP is a well-known sequelae of intrapartum asphyxia, birth trauma, and severe hyperbilirubinemia, and there are really two distinct cohorts of children who develop CP. Those that come from at-risk populations, there are about 2/3 of the children with CP. These are the kids that had a challenging or a vulnerable course after birth and spent some time in a NICU, and about 1/3 of the sample come from what I call a community in which there are no challenging or vulnerability in the newborn course, but early handedness, motor delay, clinical red flags lead to a suspicion of CP. It's a community-derived sample that usually suffers from a delay in diagnosis because most places will have a systematic surveillance of the high-risk population that has survived a stay in a NICU. And I must say again that little is known of the epidemiologic complexity of CP in low resource settings worldwide. So let's talk now about what are our prevention strategies. Well, based on what we know about the etiologic spectrum, we have certain current preventative strategies, okay? Now we are going to be challenged by the fact that you all know, and you can all recount by rote almost, that CP is a heterogeneous disorder. So no one single strategy is going to prevent all of CP. Also, you have to understand that with the probable exception of prematurity, none of them account for a significant component of CP. So any of your preventative strategies is going, if successful, will only have a small impact on the overall rates of CP. So that means if you really want to, at a system-wide level, prevent CP, you're going to have to choose multiple preventative targets. So these preventative targets that we can do now are prematurity, peripartum infection, hyperbilirubinemia, and intrapartum asphyxia. So this is like risk management, which is an appropriate term in that this get-together is being sponsored by an insurance firm. So prematurity is the single biggest determinant of later cerebral palsy. Now, what are the causes of prematurity? And the causes of prematurity are really multifactorial. If a mom receives inadequate prenatal care, she's more likely to have a premature birth. By reducing multiparity, like multiple gestations in terms of 2 or 3, which can often be the consequence of IVF treatment, that also reduces the risk of later prematurity and reduces the amount of CP. Avoiding pregnancy at the extremes of childbearing age, the teenage mom, the mom that's over the age of 40, avoiding tobacco, alcohol, or drug use during the pregnancy, avoiding short, that is less than 18-month inter-pregnancy intervals, as well as the aggressive treatment of preterm labor with the use of bed rest and tocolytics. All of these are strategies that can reduce later prematurity. There's also aggressive management during pregnancy of intercurrent maternal conditions, when the mom has high blood pressure, when the mom has diabetes, a urinary tract infection, anemia, an incompetent cervix. All of these things, by addressing them, that can decrease the rate of prematurity. However, there probably are genetic predisposition factors, and the most powerful factor that can predict later prematurity and later CP is low socioeconomic status. These are probably beyond our present modification efforts. Probably the single best thing to do is reduce alcohol or tobacco use in young moms. That will probably be the single best social strategy to reduce prematurity. Also, these strategies sort of emphasize the maxim that every pediatric resident learns in the first month of their residency, that is, if you want a healthy baby, have a healthy mom, okay? So that is very, very important. But as you can see, there's no single magic bullet to really effectively prevent prematurity, and that's why reducing prematurity rates have been fairly elusive, whether you're in a low resource or a high resource setting. Now, in prematurity, what the key CNS or brain manifestation that leads to cerebral palsy is something known as periventricular leukomalacia. Peri means around, ventricular, ventricle, that are these fluid-filled spaces in the brain, and leukomalacia, leuko meaning white, malacia meaning softening. So this is softening of the white matter around the ventricle. Now, why would let's see if I can get this right. Yeah, there you go, magic. Why did this happen? Well, you have these penetrating vessels, but there's an area that's a watershed area that's around the ventricles. So if there's inadequate blood perfusion through here, this is the area that would preferentially be affected. This is a graph of cerebral perfusion pressure versus mean arterial blood pressure. In the adult, even though our blood pressure may fluctuate over a wide range, we don't all of a sudden become sort of faint or lightheaded because we have a constant cerebral perfusion pressure over a broad range. The term infant had this constant cerebral perfusion pressure over a narrower and lower range compared to the adult. The preterm infant, this is even at a lower blood pressure, this constant range, and the constancy is over a very, very small range of blood pressure. What this means is that if the blood pressure falls below this, cerebral perfusion becomes pressure passive and there is ischemia. If it becomes above here, it still remains pressure passive, but because of too much pressure, you may get hemorrhage, okay? Then there's another aspect. This is an amazing story that's come out in the last 10 years, and mostly the work of Stephen Back in Oregon, is the maturation of the oligodendroglial cell, which is responsible for the myelination of the nerve tracts in the brain. Basically, there is a specific maturation unfolding, and in the immature oligodendroglial cell, it's particularly susceptible to ischemia. All sorts of lines of evidence showing that it just becomes more, it is more damaged by ischemia than either the pro-oligodendrocyte or the mature oligodendrocyte. And guess what? This is the predominant oligodendroglial cell type between 26 and 34-week gestation. This shows you the imaging effect. There are some radiologists in the room, so I would never presume to be more expert than a radiologist. Also, these are guided by these wonderful arrow signs that tell you where to look. Unfortunately, when the radiologist first looked at the MRI, they don't come with these arrows, right? You have to put them yourself. But this basically shows the area that tends to be affected. The configuration of the lateral horns tends to be lost. It tends to be blunted. The white matter tends to be narrower. There's also a change in signal intensity. This is a more chronic picture of what it would look like later, and you can see how, you got the squaring of, and there's also almost no white matter here between the gray matter as it ends here. So this thinning of the white matter, this squaring of the lateral horns of the ventricles, these are all classic sort of signs of periventricular leukomalacia. We used to see a lot of this in high resource setting. This is known as cystic PVL. You get the characteristic finding of the PVL, and in addition you get cyst, right subjation to the lateral ventricle. And this is a particularly bad prognostic sign. You can actually see it in severe cases on cranial ultrasound done at the, not at the bedside, but at the isolate side when the child is still in the NICU. And when you get that report, you know this kid is going to have a severe, poor outcome. Cystic PVL has more or less disappeared from a high resource setting NICUs, and we think it's because of antenatal beta-methasone usage. Somebody asked Iona the question, how did beta-methasone work? We don't know. We know in the lungs it accelerates a lung development and it avoids RDS, but in the brain, I'm not sure anybody quite knows why antenatal beta-methasone decreases cystic PVL. But we do know that our neonatologists have gotten a hell of a lot better at managing cardiorespiratory status in newborn, and there's much more cardiorespiratory stability. And that means that cerebral perfusion pressure remains more constant, and that prevents the pressure-passive ischemia or hemorrhage. We also, neonatologists have gotten superb at recognizing and aggressively treating episodes of neonatal sepsis in the NICU, and we think that successful treatment of these infections has also decreased cystic PVL. Another way we talked about how do we prevent CP? Well, if we prevent prematurity, we have some strategy to prevent PVL by better cardiorespiratory management and beta-methasone, et cetera. And also Iona alluded to this, is magnesium sulfate. It was originally being given for preeclampsia, and it still is given for preeclampsia, but observational studies noted a decreased frequency of cerebral palsy in the offspring of mothers who were given mag sulfate for preeclampsia. Again, a whole bunch of theories about why it should reduce later CP. It reduces vascular instability. It reduces pro-inflammatory cytokines or immune mediators. It decreases calcium influx into cells. It reduces free radical generation. It has a direct neuroprotective effect. All of these have been shown in cell cultures, et cetera, but the precise mechanism that is working in vivo is not yet known. There have been multiple prospective randomized controlled trials, and doing meta-analysis, this has shown a reduction of moderate to severe cerebral palsy when a mom in premature labor is given antenatal mag sulfate. The number needed to treat is 63. Keep that number in mind. and you need to treat 63 moms who are in prem labor with mag sulfate to prevent one later case of cerebral palsy if the mom is under 34 weeks gestation. Where that sounds like a lot, the low cost of magnesium sulfate leads to a very favorable cost-benefit analysis, and it basically costs about $10,000 US to prevent one case of CP. Now, if you were paying careful attention, the average cost of a child with CP over their lifetime from medical, educational, and rehab perspective is $1.5 million. Now, if I were telling you, if you gave me $10,000, I would give you back $1.5 million, you would say that's a pretty darn good return on investment, right? And it is. So that's why moms get mag sulfate. Actually, I can also sell you Bitcoin. Anybody interested? No? No, nobody quite. I actually challenged the CEO of Constantia last night to explain me Bitcoin, and he said it was he didn't really understand it. He gave me a whole explanation, but still he would not recommend it as a financial investment. Is that correct? Yeah. Anyway, if something sounds too good, it probably is too good. Anyway, this is the meta-analysis, and it basically shows that, when you put all the stats together, you get a narrower confidence interval, and this bottom thing shows you that there is a risk reduction below 1, and the confidence interval doesn't cross 1, so this means that it is believable when using mag sulfate. And of course, only one of these studies, it didn't cross 1 in and of itself, but when you combined all these numbers, you get this statistical robustness. And this is also shown in this table diagram, basically showing that it depended on the study, but to avoid death or CP, to avoid CP, it's basically about 63 to 1 under 34 weeks. And this is generally the cutoff for giving mag sulfate on a routine basis to moms in prem labor. So what we do locally is antenatal mag sulfate for an imminent delivery under 34 weeks gestation, and we give 4 grams IV over 30 minutes, followed by 1 gram an hour. The other preventative strategy is that the recent story in the last decade or 15 years that peripartum infection, especially chorioamnionitis, either clinically or pathologically proven, shows to increase later risk of CP. This probably reflects the pro-inflammatory cytokines that come along with a maternal chorioamnionitis, and these are mediators or augmenters of an acquired brain injury both in preterm and term infants. The literature is quite clear. There's increased later cerebral palsy rate in the setting of documented chorioamnionitis. So how did this translate into a prevention strategy? Aggressive antibiotic treatment of moms who have a positive GBS status before they deliver, antibiotic treatment of maternal fever, and other clinical signs of chorioamnionitis, such as abdominal pain or tenderness, and by reducing premature rupture of membrane and delivering babies before there is a prolonged premature rupture of membrane. All of these are intervention strategies that, if applied consistently, should have some effect in reducing later cerebral palsy. Hyperbilirubinemia is it's not a major cause of CP in high resource setting, but certainly in my short visit to the University of Pretoria, it seems to be a more common cause in low resource settings within South Africa. And bilirubin encephalopathy, or connectris, includes dyskinetic cerebral palsy, which can be quite severe and incapacitating. It also comes along with deafness. This occurred in the setting of prematurity, the small for gestational age baby, the baby who experienced sepsis or hemolysis, and in very rare disorders of bilirubin conjugation, such as Crigler-Najjar syndrome, you have a setup for high unconjugated bilirubin, and therefore a high risk for connectris. So what's the prevention strategy? Routine bilirubin monitoring, expecting phototherapy, and the ability to do exchange transfusion and plasmapheresis when necessary. Another prevention strategy relates to asphyxia, which we said may be present in about 20% of cases of CP, and about half of those have a prenatal predisposing condition. There have been several well-done, established randomized controlled trials which show that it's an effective neuroprotective strategy for term intrapartum asphyxia, and by reducing later disability, and they primarily looked at cerebral palsy and death. So the results have been the development of cooling criteria, the establishment of regional cooling centers, and with peripheral birthing centers, whether it be in community hospitals or in birthing centers which are run by midwives, are connected into the regional cooling center. And there's a rather rapid strategy for children who recognizing children who have potential intrapartum asphyxia and newborn encephalopathy to get them transferred to a level 3 NICU which had this cooling capacity, and to apply it within the window of opportunity, which is now recognized as 6 hours after birth. It is now a standard of practice, and it basically demonstrates how child neurology is transitioning from a descriptive to an interventional discipline. We tend to cool children who are 37 weeks gestational age or greater. Some people extend this to involve the late preterms. The study that was being done to look at late preterms highlighted a higher hemorrhage rate in those patients, so people are a bit reluctant to extend it to late preterm. The children that we cool have a greater than 2 kilo birth weight. We do it within 6 hours. But what's magic about the difference between 5 hours and 59 minutes and 6 hours and 1 minute? I don't know. And this is particularly challenging in a country the size of Canada, where we're responsible for hospitals that are 1,500 kilometers from us, and trying to transfer these children down within the 6 hours can be quite difficult. The children also have to have a sign that suggests possible intrapartum asphyxia in etiology, such as a low APGAR score at 10 minutes, a cord gas or a baby gas within the first hour that's acidotic with a pH below 7, the need for case room resuscitation with compressions or ventilation beyond 10 minutes, or the evidence of a sentinel event. We also want all these children to have a moderate or severe neonatal encephalopathy. Yes, we do cool severe children, even though the prospective study did not demonstrate a benefit to them. I think that reflects the medical bias to do something rather than nothing. And so these are children who have had newborn seizures, or have brainstem findings, or have evidence of seizures or depressed amplitude integrated EEG. And we cool them to 34 degrees, and we keep them cool for 72 hours. I'll be happy to share this cooling protocol that we have at the Children's with anybody if they're interested. Just email me. But basically, we did a lot of work in knowledge translation and knowledge mobilization to get the word out that there now was a treatment for these children, and what would assign to recognize a child who might benefit from cooling. And as I said yesterday, we cast a wide net. We are much happier to have these child be referred in and then reject some of them ultimately for cooling, rather than miss any children in the peripheral hospital. And it created a tsunami of cases that we have, and it basically these children were not getting to a level 3 NICU before, but now are. We also looked at how much of cerebral palsy after neonatal encephalopathy is preventable now that we have cooling. And we based this on data that we had from the Canadian Cerebral Palsy Registry. As I mentioned before, the registry is a population-based approach to capturing CP. It's multi-regional, doesn't cover all the areas of Canada, but covered roughly half of our birth cohort. And what we did was we identified those term-born infants with CP who had a documented moderate to severe neonatal encephalopathy. And then we looked at those and said which one of those would have been eligible for therapeutic hypothermia And if we applied the results of the randomized controlled trials in cooling were applied to our actual numbers, and all of the children who were eligible for cooling got cooling, how much of later CP could we prevent with cooling? At that time, we had 1,000 individuals in the registry. We now have twice as many. Roughly 55%, or 543, were term-born. Roughly a little less than 30% had moderate to severe neonatal encephalopathy, and a subset of those, roughly 41%, met cooling criteria. So the meta-analysis that I presented yesterday of cooling revealed a number needed to treat of 8, that's a lot better than 63, to prevent 1 later case of CP. So basically, in our cohort, CP with cooling would prevent 8 of 64. Number needed to treat is, let's say, 8. That means the grand total of 8 kids with CP would have been prevented if all of these children were referred to a cooling center. In the best case scenario, if we extended the benefit of cooling to all children with moderate to severe neonatal encephalopathy, and nobody had shown that, we would prevent 19 cases of CP nationally. Not a big number, adds up to about 3%, but something, okay? So there's a limited impact overall because asphyxia is not a predominant cause of CP, but it does have substantial impact. So it is justified from an individual, family, and societal perspective, and it is a necessary cost and resource availability in a high-resource setting such as one that I'm coming from. Now, other management issues in CP, let's talk about the core feature neuromotor impairment, 85% spasticity, and the concomitant motor delay. What this means to me is that every child with CP should be referred to our friends in physiotherapy and occupational therapy. What do they do? They minimize spasticity through passive stretching and AFOs and splinting. They maximize function and participation through mobilization and the application of aids and adaptation. For hemiplegia, constraint-induced movement therapy has been shown to be an effective aid to not necessarily preventing CP, but certainly improving hand function. And this involved the restraint of the non-paretic, that's the wrong, non-paretic upper extremity that forces the child to use the paretic extremity. Speech and communication difficulties, which many of these children had, mandates referral to a speech-language pathologist. Basically, lifelong functional status for these children in the gross motor, fine motor, and communication domain is achieved by 6 years of age. What is done afterwards does not represent functional gain, but represent minimizing various impairments and minimizing the deterioration, as was shown by Ona in her talk earlier today. Hypertonia and consist of spasticity and dystonia. They are the major challenges in the management of the movement disorder that is CP. Hypertonia is a velocity-dependent increased resistance to stress. The patient also tends to have a spastic cast as you move the limb through its range of motion. That occurs in about 85% of children with CP. Dystonia occurs in about 8 to 10% of our kids with CP, and this involves sustained simultaneous contractions of agonist and antagonist muscle pairs that results in like a twisting movement and abnormal postures. It can be elicited by tactile stimuli or voluntary movement, and the characteristic description is a lead pipe type of rigidity. Now, there are medical and surgical interventions to be considered in the context of spasticity when spasticity impacts on care or participation or gives the child pain and discomfort. Pharmacologic approaches, Botox, given focally into the lower or upper extremities. Botox works only if combined with intensive physiotherapy. We have a variety of GABA agonists can be given orally, such as baclofen or Lioresal. Diazepam or Valium can also be used, but that tends to have more sedating properties. Some people use, but I haven't really much effect, alpha-2 adrenergic agonists such as tizanidine. The surgeons have a number of different approaches. The orthopod earlier today described a variety of tendon releases that can be used. We have a very active program employing selective dorsal rhizotomy, which is sectioning of some, and then the key word is selective, of the roots, of the sensory roots between L1 and S2. This is directed primarily at children with GMFCS level 2 or level 3 spastic diplegia. They need to have adequate truncal stability, and it also needs to be combined with intensive physiotherapy to be maximally effective. We also use a lot of an intrathecal baclofen pump. If the child is getting a benefit from oral baclofen and has a GMFCS level 4 or 5 spastic quadriplegia, we may proceed to a baclofen pump. It leads to less sedation and it improves spasticity and also lessens the burden of care. The child gets, remember, these are GMFCS level in 4s and 5s. They're not very mobile. Mom spends a lot of time, in terms of dressing or transferring the children, and this can make it easier for them. In hemiplegic CP, this is often the result of a prepartum or peripartum arterial ischemic stroke. There's a recent randomized controlled trial out of Alberta, Canada, in which they combined transcranial magnetic stimulation on the side opposite the side with the lesion and constraint-induced movement therapy, and they were shown to be significant improvement on the assisted hand assessment and the Canadian occupational performance measurement. They were demonstrating gains in function, and the feeling was that they were enhancing neuroplasticity. So for dystonia, one can apply the spasticity strategies because often there is associated spasticity with the dystonia, and in addition, anticholinergics such as trihexyphenidyl or artane or bentropin or congentin is also known to be effective in decreasing dystonia. Sometimes you throw all the medications you have, and I would emphasize that dystonia is a particularly challenging medical management situation for any neurologist, and you can sometimes run out of options, or options are not effective, or you run into side effects, and the result is you consider deep brain stimulation, which is functional neurosurgery, in which under stereotactic guidance they implant a stimulator into the globus pallidus interna. This is really remarkable. And they turn a switch on, and it stimulates electrical pulses, and that may improve the dystonia. Very few centers in the world that can do this. My understanding is that that's not an option at present in South Africa. Comorbidities occur frequently in CP. More than half the kids with CP will have one or more comorbidity. It's a wide spectrum. As I mentioned before, it's often a major challenge. And as I showed yesterday from our registry, it's not randomly distributed. Some children have a disproportionate burden of the comorbidities that occur in CP. These tend to be the children with an increased gross motor severity, those at level 4 and 5, as well as those with spastic quadriparetic, dyskinetic, or mixed CP. These are the numbers that are associated with the comorbidity frequency. And you see, 75% of kids with CP will have pain. Half will have an intellectual or learning disability. A third will have epilepsy. A third will be non-ambulatory. A third will have hip dislocation. 25% will have a behavior problem. 25% will have a sleep disorder. 25% will be nonverbal. 20% will have excessive drooling. 15% will have no functional hand use. 10% will have a significant visual impairment. 10% will have moderate to severe scoliosis that will require treatment and ultimately operative intervention. 8% will be tube-fed. 4% will have a significant auditory impairment. This is one of the reasons why to know CP, you know child neurology, because this is the entire comorbidity spectrum that you see in a child neurology clinic. and it occurred within a single symptom complex. So you got to identify the comorbidities. You do so by screening for hearing and vision, by screening for hip dislocation and scoliosis, as outlined by the orthopod previously. Then you do surveillance. You ask the parent for each time visit about any specific concerns or issues. The treatment in comorbidities is targeted, it's individualized, and it's multidisciplinary. Intellectual learning challenges, call in a psychologist. Musculoskeletal issues, call in the orthopod and the physiotherapist. Behavior challenges, psychologists and psychiatrists. Speech and language limitations, speech-language pathology. Excessive drooling, speech-language pathology may be helpful. The ENT doc with their intrasalivary injections of Botox or with the salivary duct ligation can be very helpful. Reduced hand function, problems with ADLs, call in the occupational therapist. Feeding issues, GI or occupational therapy. I recently had the experience of transferring a child that I had followed since birth. The kid was a high-risk newborn survivor, then developed later CP. I'm old enough to have patients that I saw as newborn graduate from my practice at 18. I counted up the number of health professionals from different specialties and different orientations who had interacted with this child and family. Anybody want to guess how many they were? Come on, call out a number, loud. 50? It was 24. 24 different specialists had helped me out and had helped the transition of that child and family to adulthood. So the other thing that you need to medically respond to are paroxysmal disorders. Not everything that shakes is epileptic, okay? And that's a very, very important sequitur in child neurology. Everybody blames anything that shakes as epilepsy. No, you have to verify that it's indeed epileptic in origin. Sometimes that required prolonged or video recording. It requires sometimes ambulatory recording. The choice of an anticonvulsant, nothing special about CP. It's based on the type of seizure. You avoid polypharmacy because you run into more side effects. And certainly in the setting of CP, surgery, at least in our context, is an option if the seizures prove intractable and it's focal, originating in what we call non-eloquent cortex. And just like children who are typically developing, if they're seizure-free, we will consider a trial off medication if they're seizure-free after 2 years. Unfortunately, children with CP are more likely to relapse than the typically developing child during such a thing. In terms of other medical responses, pain. I'll admit, I don't do a very good job with pain in CP. I don't think anybody does. It's often unappreciated and it's definitely undertreated. But you can do some simple things: proper positioning, support, bubble mattresses, adapted seating, treating the underlying spasticity or dystonia, especially severe, getting the orthopod to help out with orthopedic deformities such as contractures, treating the hip dislocation, the scoliosis. Simple thing, treating constipation with laxative. If they have reflux, using proton pump inhibitors, maybe changing their positioning when feed, thickening the feed. Sometimes a surgical intervention like a fundoplication or a gastrostomy tube can help. Undernutrition can be a source of pain. So attacking pain in a child with CP is often multifactorial, but it does lead to an improved quality of life and satisfaction. Behavior challenge, another area tremendously under-recognized, underappreciated, and probably not as well treated. Many of these children have attentional limitations and hyperactivity. There's no reason why not to use stimulant and non-stimulant options, but we tend to use it at a lower dose than in typically developing children because they're more likely to have side effects. They can be just as oppositional or aggressive as a typically developing child, if not more so. Atypical antipsychotic can be effective in that situation. And again, affective disorders, anxiety occur at a higher frequency in children with CP compared to typically developing children. And selective serotonin, speech and language limitations, speech-language pathology. Excessive drooling, speech-language pathology may be helpful. The ENT doc with their intrasalivary injections of Botox or with their salivary duct ligation can be very helpful. Reduced hand function, problems with ADLs, call in the occupational therapist. Feeding issues, GI or occupational therapy. I recently had the experience of transferring a child that I had followed since birth the kid was a high-risk newborn survivor, then developed later CP. I'm old enough to have patients that I saw as newborn graduate from my practice at 18. I counted up the number of health professionals from different specialties and different orientations who had interacted with this child and family. Anybody want to guess how many they were? Come on, call out a number, loud. 50? It was 24. 24 different specialists had helped me out and had helped the transition of that child and family to adulthood. So, the other thing that you need to medically respond to are paroxysmal disorders. Not everything that shakes is epileptic, okay? And that's a very, very important sequitur in child neurology. You know, everybody blames anything that shakes as epilepsy. No, you have to verify that it's indeed epileptic in origin. Sometimes that required prolonged or video recording. It requires sometimes ambulatory recording. The choice of an anticonvulsant, nothing special about CP. It's based on the type of seizure. You avoid polypharmacy because you run into more side effects. And certainly in the setting of CP, surgery, at least in our context, is an option if the seizures prove intractable and is focal, originating in what we call non-eloquent cortex. And just like children who are typically developing, if they're seizure-free, we will consider a trial off medication if they're seizure-free after 2 years. Unfortunately, children with CP are more likely to relapse than the typically developing child during such a thing. In terms of other medical responses, pain. I'll admit, I don't do a very good job with pain in CP. I don't think anybody does. It's often unappreciated and it's definitely undertreated. But you can do some simple things: proper positioning, support, bubble mattresses, adapted seating, treating the underlying spasticity or dystonia, especially severe, getting the orthopod to help out with orthopedic deformities such as contractures, treating the hip dislocation, the scoliosis. Simple thing, treating constipation with laxative. If they have reflux, using proton pump inhibitors, maybe changing their positioning when feed, thickening the feed. Sometimes a surgical intervention like a fundoplication or a gastrostomy tube can help. Undernutrition can be a source of pain. So attacking pain in a child with CP is often multifactorial, but it does lead to an improved quality of life and satisfaction. Behavior challenge, another area, tremendously under-recognized, underappreciated, and probably not as well treated. Many of these children have attentional limitations and hyperactivity. There's no reason why not to use stimulant and non-stimulant options, but you tend to use it at a lower dose than in typically developing children because they're more likely to have side effects. They can be just as oppositional or aggressive as a typically developing child, if not more so. Atypical antipsychotic can be effective in that situation. And again, affective disorders, anxiety occur at a higher frequency in children with CP compared to typically developing children. And selective serotonin reuptake inhibitors are effective in this population. Sleep, another underappreciated, underrecognized, underaddressed problem. We have a whole series of papers that will be coming out over the next year about sleep problems in children with CP. It's primarily disorders of initiating and maintaining sleep, that is falling asleep and staying asleep, pain and discomfort may be the underlying cause. They need regular sleep hygiene, and we found in our population that melatonin and clonazepam were beneficial. Don't underestimate the impact of excessive drooling. It may limit socialization and even like the family enjoying a meal out at a restaurant together because the child is drooling so much. Intrasalivary Botox toxins work. Call in ENT, and for the refractory child, salivary duct ligation. So just go over some of the key points. If we wanted to prevent CP, better maternal health. Remember, healthy mom, healthy baby, better access to antenatal care, and treating intercurrent complications and maternal conditions during pregnancy. Prevention of prematurity, good luck with that. That's multifactorial. It required perhaps some social engineering and some real advances in genetics. Recognizing and treating chorioamnionitis. Mag sulfate when the mom is in prem labor at 34 weeks or less, and that will lessen your PVLs. Cooling for term asphyxia, but the challenge is in low resource setting is to have access to cooling technology, but perhaps there are low-cost cooling options that can be used, and preventing bilirubin encephalopathy through aggressive phototherapy and exchange transfusion. Management, we're not going to cure anything, okay? But we certainly can make every child we encounter better by paying careful attention to what is their problem. Sometimes, you have a kid who has CP and is having frequent seizures, and there you are spending all your time trying to control the seizures, but if you listen to the mom, she may tell you that the main issue may be behavioral, it may be sleep, it may be related to excessive drooling. So it's customized, it's individualized, and it's symptom specific. And the goal always should be, optimizing outcome, improving participation, and lessening the burden of care. So I just want to thank you for your attention, and I'll be happy to answer any questions that you may have. And this is a glory. I understand we're getting 15 centimeters of snow in Montreal today. So this is what my university campus would look like, but I'm not going to see it.
Hopefully you can have a nice walk in the sun.
Yeah, that's right.
Is it raining?
Raining? Oh, my God. Okay. Thank you.